So now what will we have? We're going to have improving discharge practices in cardiology wards. Okay, so now we'll call the team from Singapore. Oh, you're back.
Yeah, I'm from Singapore, you know.
Yeah, sure. We'll leave you guys there. Bye-bye.
Okay, thank you very much, Chris. Now we're going to present a very, very, very good project from healthcare. It's a common project in most of the hospitals, but not always can be solved in the way that these hospitals have been solved. And we're not talking of just a hospital. It's one of the best 10 hospitals in the world, probably in one of the best services in the world. So a lot of curiosity to understand what's happening here. So I'm going to introduce you. We have here Dr. Kenneth, is probably the core of this team. Also, we have Sogyi, also from the National Health Service, that it's probably the one that it's oiling all these years to really work. We have Angelina from SIT, who is the knowledge of this project. And finally, Denise, that has been also on this project, and myself from the Link Global Connection. But I'm going to give the word to Dr. Kenneth because everything started in one morning.
All right. Thanks very much, Oriel, and good morning, everyone from Singapore. So I think we're just going to start with these slides. So if we can kind of put up the slides, and just for a split second there, we had a text message from our head of department. So stop me if I can trouble you to just put it up.
Yeah, just a moment.
So we tend to get these text messages when something is going a little bit amiss. And just to set the background, we had a week of very bad kind of congestion on the ward. We had a lot of admissions, and we had a lot of patients waiting to be discharged, and really the backlog was kind of piling up. We had patients waiting on the ward, and we had patients waiting in the emergency department. And then it got to a point where really our head of department sent an SOS message, and the message here. So there are a number of patients waiting at the A&E for beds, of which they've been waiting for more than X number of hours, and it was a lot of hours. It was almost like half a day to 1 day. Something that had been happening on a daily basis, and some of them were having chest pain and all of that. So we need beds, and we need our patients discharged as early as possible. Can someone do something? And this was a big problem. That thank goodness we had the help of Angelina and Oriel, and I'm just going to introduce Angelina, and this is really how our project got started.
Hi, Kenneth.
Yeah,
Hi,
thank you.
Sogyi.
Yeah.
Hi, Sogyi. What is the problem? How could I help you guys?
Actually, what Kenneth had mentioned, we have discharge delays in discharges, and a lot of patients are waiting to come into National Heart Centre's ward. So we're actually looking for a solution, and I have actually came across and know about Singapore Institute of Technology having a program to link to collaborate with the Lean Global Network for a project to start with implementing Lean in National Heart Centre. So could you link us up to the Lean Global Network?
Yes, certainly. This really sounds like a problem that Lean can definitely solve. So yes, we have a program at SIT that can train NHCS staff in Lean and at the same time apply the learnings to solve the problem that you are facing. So it sounds like a big problem. So let me bring in some reinforcements from the Lean Global Network. Oriel, are you there?
Oh, good morning. It's so early. Time difference, you know. Okay, tell me, Angelina, what's the problem?
Yeah, so NHCS is facing a problem with their patient discharge processes. There are so many patients waiting at the A&E for the beds in the wards, so they need help to smoothen their discharge processes. I'm pretty sure Lean will be good in this so that they can discharge earlier and get patients into the ward earlier.
Yes, in fact, this is a very good project. It's one of the best projects that a hospital or any service can afford. Why? Because having discharge and early discharge means that everything is perfect. Means that doctor has a perfect day, that test has a perfect day, that nurses have a perfect day, that admin has a perfect day, that families has a perfect day. So if we have all the standards, if we have everything flowing, then we can make the charge before 12 or before 11 or the early discharge. So really, this is a very good program. And this is a problem that I think that I have all the hospitals around the world. So you are very brave to try to face it. So yes, Denise from Australia and myself, we are very, very, very happy to join this program and to join this challenge because this is a real challenge. And but how do you want to manage that? Dr. Kenneth, how do you want to do that?
Yeah. So I think that's very interesting, and I just want to moving on to this slide, where we actually have a roadmap of how we went about doing Lean. You know, when we started off, none of us knew anything about Lean, and it was very difficult because it was during COVID. We started last year in November, and we started to learn about Lean in November, and it was all done virtually. And you can see that this is our group photo. It's not just the three of us, or rather not just the four of us, but it's a really big team here. The bottom picture, and moving on to the next slide. This was our implementation timeline. So we spent November really learning about Lean on Zoom. And then between March and May, we started to implement what we had learned. We started to make observations on the ward, and we started to do small experiments on the ward. It was only during from July to September where Oriel was able to actually come down to Singapore to help us out on the ward. And we had two very fruitful Lean weeks in July, one in July and one in September, where we actually implemented things like visual boards and a plan for every patient board and the 5S on one ward at first in July. And then in September, there was a lot of demand to expand the projects. We implemented it in another ward. And we're going to be talking about all of these things in the next couple of slides. So moving on to the next slide. Now, what we were trying to achieve and what Oriel really taught us was that for any kind of improvement to happen, we needed a standardization of work. And up until then, there was no real standard of discharge. You know, there was no standardized way that a doctor or a nurse would discharge a patient who was able to go home. And what we aimed to do was to achieve stability in our discharge processes, and that would form the foundation of any kind of improvement. Okay, over to the next slide. Now, what we found during our observations before Oriel came, between October 2021 and February this year, was that there was a lot of movement on the ward, and you can see kind of like a spaghetti diagram here, where you'd have doctors and nurses going in and out, back and forth, with not a lot of necessarily a lot of purpose or a lot of results, a lot of movement, but not a lot of results. And you had a lot of competing work streams, a lot of competing processes, doctors and nurses doing different things, and very little interface and very little communication between the two groups. Now over to the next slide. And what we did was we broke everything down. We broke down everything that a doctor or a nurse did on any given day relating to discharge. And then we did something called a precedence diagram, where we broke down what was necessary to discharge and what was not. And then we also did some value stream mapping. And then we did a reorganization of their daily routine to try to bring the discharge forward to much earlier in the day than it was at the time. Okay, over to the next slide. Oh, I forgot to say, Aurel, if you have anything that you'd like to discuss about or ask.
Yes, one of the things that I think it's important when Kenneth say about this miscommunication, this was real because doctors work with their work and they maybe we don't care what the other people has or need, or and nurses as well. Nurses work with their own work without too much connection with the doctors and with the families. And sometimes, let's say that doctor didn't care if we have called the family early or not, because this is not their work. Maybe this is nurse work. And nurse say, and when we ask to the nurses, yes, but do you know which patient is going to be discharged? And say, it is not our work. This is doctor work. But at the end, there is a lot of miscommunication because we understand that as this is not my work, I don't have to care about that. And really, we have to care about all the other people work because this is a transversal vision. So I think that these messages that Kenneth has been saying, it's very important because really this is happening in most hospitals in the world, that we have too much work that we just care in the work that we have to do on myself. Because if after my work I have to take care on the other people work, wow, this is too much work, too much work. And this was the seed of this probably of this miscommunication. This was very, very interesting, Ken. Very, very interesting.
Yeah. All right. So moving on to the next slide. So now, so we kind of reorganized everything, and what we decided was that there were two very important things that had to be done. One was that the patient had to be pre-discharged. What does a pre-discharge mean? It means that 1 day before the discharge or 2 days before, there had to be some planning and some steps taken to bring some of the work that was involved in discharging a patient away from the actual day and doing it 1 to 2 days before, because on the actual day it was just too much of a rush. There was not enough time to do everything, and that's why patients would go home in the late afternoon or in the early evening. Now, to do a pre-discharge, what the medical officer had to do was to prepare some documentation that, most importantly, informed the next of kin, the patient's family, whoever was going to bring the patient back home, that the patient was going to be discharged at 12 noon the next day. And 12 noon was our target because we were having patients going home at 4 o'clock in the afternoon, and that was much too late. We even prepared a script for our doctors and our nurses on what to say. Now, moving on to the next slide.
Let me say that not in NHCS, but in many, many hospitals, pre-discharge is a myth. Everybody knows that it exists, but nobody has seen that. Okay, so for not in this hospital, but in many, many hospitals, is a myth. Is a myth.
So now I have to say that before Oriel came, our pre-discharge, some people were doing it, some people were not, and like a good doctor, a good junior doctor would do it, and an average one would not. So we wanted to standardize everything. Now, on the day of discharge, the next step was that we somehow had to communicate that the patients could go home, and this was very difficult because when doctors did their morning ward round, which would happen at something like 8:30, the nurses would be serving medication, doing other things. And we actually encouraged, first of all, we encouraged the attending doctor or the consultant to see discharge cases first. Basically what we found was that when a decision was being made for a patient to go home, that decision was not being communicated very well. So, the doctor would write in the electronic records that the patient could go home, but the nurses would only find out, after their break or after doing their medication, after so many things, and they would only go home. They would only actually realize what the plan was maybe at kind of 10 o'clock. And what we wanted to do was to bring that forward. We wanted the decision to be communicated much earlier. We wanted discharge summaries, prescriptions to be printed by 11 a.m. And then we also wanted the next of kin to be coming much earlier. Yeah, so moving on to the next slide. So now this was basically a time chart on what was being done the day before and what was to be done on the day. But I think we can elaborate on this a bit later. Now, moving on to the next slide. Now, how could we implement good communication? It was difficult to do it face-to-face because we couldn't have our doctors chasing after the nurse and saying, oh, this patient here can go home. The nurse would be serving medication. The nurse would be busy. We also could not tear up the entire doctor's or nurse workflow and say, this is kind of like how you've been doing it for years and years and years, for decades, and then kind of say nurses have to come to work at a certain time, doctors have to come to work at a certain time. So what we did instead was we implemented these visual boards, which were communication platforms. And we're going to play a video. So I think Oriel has prepared a video. We're going to play it to explain how that was implemented.
At one of the cubicle, and we started a lean project which will help us have effective communication between doctors and nurses and make sure that everything is in place and nothing is missed out.
Good morning, everyone. I'm Dr. Kenneth Chu. This is Dr. Jared. So we're from the National Heart Centre, Singapore. So today we're going to explain our lean solutions for our cardiac ward. We're both cardiologists. We discovered on some observations earlier on in the week that we actually had two processes running between doctors and nurses without much communication between the two workflows. And this is a solution which we are trying on the ward to solve this issue and also expedite discharges. So over to Dr. Jared. Yeah.
Maybe I'll start by explaining how this board works. So one of the underlying problems on a daily basis is that the ward notes change quite dynamically. The nurses cannot always keep track of how or when the notes are changed. So we have a real-time board over here, shown on my left, that is meant to facilitate easy communication and changes, essentially. So quite a few things are going on in this board. I'll start to explain. On the extreme left column, there's the patient details and the bed number. The next column, titled OK, and the following update. These two columns refer to the status of the clinical documents. OK means that whatever's written at this moment is the most updated version. When we make any changes during the day, we will shift the magnet from OK to update. And the nurses that walk by see this change in magnet on the update column, and they'll know to check the CDoc, the clinical documents. And once the changes are done, they'll put it back. So those two columns were for the clin docs. PD is the planned discharge date. So we plan in advance and we write a date that we think the patient will be able to go home on. The column on the right of that, D, is a column for the magnet to move as well. So if a patient is planned for discharge today, we will shift the magnet from the left column to the D column. So likewise, the nurses will know that this patient is planned for discharge today. And one of the key things before allowing a discharge is to call the families. So the last column, F, is for families. So it will either be written as doctors or nurses, meaning if it's written as doctors, means the doctors will be the ones updating. if it's nurses, the nurses will be the ones updating the family. So once it's done, it'll also be reflected, and the time of the discharge, the time of which the family can come down, will also be reflected. I mean, essentially that's how the board works.
All right, so so that was our video, and you know, this was kind of in. Oh, hello. Yeah, so this was kind of in July, where we were. This is Oriel's first visit, actually. So we were kind of getting our team together. Now, just to summarize, this was our visual board, and this was a single unit display to quickly view the care status for all patients in the room. Visibility would promote better accountability, and would promote better communication and implementation of actionable items like discharges. And this was supposed to promote flow in our patients, and in the end, bring forward the discharge and reduce their length of stay. Now, this was a way to standardize the daily work process and improve teamwork. All right, so, and there's a doctor's board, there was a nurse's board. Now, you know, a lot of people were saying, was this adding to the work that a doctor or a nurse had to do? And we were worried about this as well. And, you know, and I think a lot of doctors were also saying, you know, should we do this electronically? Would it be better? But actually what we found was that, you know, a simple physical whiteboard with simple magnets was the easiest. And, you know, like the time taken to update this board was less than 1 minute. All right, moving on to the next slide. So very easy. Now, this was how to update the visual board, but we showed that in the video. We're going to move on. Yeah, so over to the next slide. Now, the next important piece in the puzzle was the plan for every patient board. I'm just going to play a video describing how that was done.
Hello, I'm Ifan. I'm one of the cardio MOs from Ward 47. I'll be introducing you the master board. This master board is located in Ward 47 in our medical officer room, where all the nurses and doctors can have access to it. Looking at the board, we have the first column where we have all the patients' names, where we change them every day, and we will put different markers to represent different things. The first marker is the yellow marker, which represents the date of admission. So we will place them on the specific date that they're admitted. The pink marker represents any procedures or scans that the patients are planned for. For example, an echo scan over here, or a MEB scan, or a cath, an angiogram over here. So we'll place them on the date that they're predicted to have the scan or the procedure. The third marker is the green marker, which represents the date of the planned discharge. So this is quite useful for the nurses to also know when the patients are expected to be discharged, so that they can preempt the family in advance. So for example, in this case, we have bed 5, Mr. Tam, who was admitted on the 13th, and he is planned for an echo on the 14th, and we expect him to be discharged on the 17th. Looking at, taking today for an example, today is the 15th of September. Looking at the board, we can expect to have 4 discharges tomorrow. This one, this one, this one, and this one. So we will usually discuss with the nurses at about 3 o'clock who to inform the family about the discharge. It's either the doctors or the nurses that will give the family an update and to let them know in advance to come to the hospital earlier for the discharge. Looking at the board itself, we can also predict who will be discharged in the next 2 or 3 days. So we can, whenever we give a family update, we can also inform them about the discharge timing and let them know in advance to come early. Okay. So this is our master board.
Hi, my name is Siti. So I'm the nurse clinician in Ward 56, which is a cardiothoracic ward. So with the new implementation of this board, it has actually created a seamless process for discharge for the patients. So the routine is that daily we will meet up in one of the rooms to discuss about the patient's condition and when is the planned date of discharge. So if the doctors and the nurses will discuss, and then we will update each other on what is the latest about the patient's condition. So for example, if the patients are planned for home tomorrow, or the next day, so the doctors will inform us whether they will be doing the calling or the nurses will be doing the calling. So for example, if the patients are to be discharged 2 days later, so the doctors will be the one updating the family on the plan of discharge. So our target is to discharge the patient by 11 to 12 p.m. the next day. Okay, then when we have finalized on who is for home the next day, so the nurses will give the patient's family a call in the afternoon to inform them that they can be discharged at 11 to 12 the next day. They also will be informed that there is another call that will be made on the day of discharge itself to confirm that patient will be going home that day. As of now, we have received positive feedbacks from family members and also the nursing staff, being that we are able to discharge the patient promptly, and family can arrive in the hospital and have everything available and ready for them to bring the family members home.
Perfect.
Okay.
All right. Okay, so I think short of time, so just quickly back to the slides. So that's a plan for every patient board explained in the video. That would help us to decide who we could pre-discharge. Moving on to the next slide. And the nurses and the doctors would have a 3 p.m. pre-discharge huddle every day. Moving on to the next slide. And this was the final ward daily standard. Every morning they would update the whiteboard. Every afternoon they would hold a pre-discharge meeting with a plan for every patient board. And moving on to the next slide. And this was the daily discharge workflow implemented finally in September, when Oriel came to visit us the second time. Okay, next slide. Now we just want to show one last thing, which was the 5S, which Song Yi is going to talk to us about. So over to Song Yi.
Yeah, thank you, Kenneth. Okay, so before I share the video, just to introduce how we came about doing the 5S is actually during the program, we found new opportunity to improve the 5S in the ward, which helps to improve the overall patient and patient safety as well as the staff safety. So probably you can watch the video first before I carry on to explain what has been implemented.
Good afternoon, I'm Chin Hian. We are in this lean project, and today you can see that there's some color liner here to demarcate and indicate the purpose and function of this line. Yellow is for item like trolleys to be stationed there and not to be removed. Green is that for any item that can be parked there temporarily and be mobile and will be back again to the same place. For the red color indicator, it means that nothing to be placed there. It's to be clear at all times. This time, the purpose is that all this thing is on one side, while the rest of this corridor is clear for patient, for trolley, for staff movement. At the same time, it's for safety. There's no clutter in a full flow, free flow.
Okay, I think we are running out of time. So let me summarize what we have done. So before 5S that we have said, there's no designated location for our trolleys, computers and equipment. And those equipments and trolleys and computers are actually randomly parked along the corridor, which obstructs workflow and also patient flow. And with the 5S, we have actually created markings, visual markings on the floor to help staff to park their equipment at the right location. Like for example, I've mentioned yellow zone are for case note trolleys. They are fixed. They should not be moved around. The green zones are for movable equipments like the computers on wheels, vital signs equipment, and anything that has to be wheeled here. But at the end of the day, it has to be actually stored away back to the original location. And then the red zone are those areas that is not restricted, and nothing has to be stored there. So with that, there's a less cluttered corridor. And I will end off with my last slide to show how beneficial it is for our nursing and patient flow. And you can see this is actually a picture that's taken when you can see a patient happy walking along the corridor unobstructed with a handrail. Before this, 5S is not possible. And you could see, with this success, we also replicated the same 5S to 2 other wards as well. So with that, I think,
I
Oriol,
think
do you have
that
any?
Oriol?
Yes.
this was excellent, and I think that if Kenneth, you just can share results in 20 seconds, because I think it's impressive what you have achieved.
Sure. Yeah. So I think just the last slide, it's okay, but we basically brought forward the discharge time from 4 o'clock to an average of 1:40 p.m. So I think that was the result of all of the hard work from the team.
This was amazing. So remember, first thing was to remove the problems, communication mainly. Then it was to create the standard, all the standardization that Kenneth has been showing. And finally, to create a plan after having all these standards. So very good work, team. Very proud to be part of this and a small part. And thank you very much for sharing all of this with us. So, Chris, now we have to continue, probably not with the high level of Singapore, but well, we can continue.
Thank you.
Thank you. Thank you, Singapore. Thank you, Oriol.